Thank you.
Yeah, I know. I just wanted to single you up, make you feel good. Dr. Carly Smith, we're delighted to have her amongst us. She is finishing up her PhD at the University of Oregon this summer. She has already defended her dissertation, but she's doing a year's clinical internship in the psychology department at Yale, which is where she's coming from right now. Clinical internship there. Her field is clinical psychology, and her current focus is institutional betrayal in healthcare. And just yesterday, an article dealing with institutional betrayal came out in Time magazine, and it features one of the things that they're doing at Yale. Mm-hmm. So congratulations on that, and you seem to be involved in a hot and sexy topic right now, so we're ready for you.
Excellent. Thank you so much. So happy you guys are associating my talk and what I'm about to do with eating, so hopefully this will be slightly more pleasurable than it sometimes is to talk about this. Okay, so thank you for having me here. I'm totally jazzed to get to do this. I'm so excited to be here applying for this job, and I'm really excited to come and talk about my research. I'm on a clinical year, as Kimberly mentioned, so I kind of have to turn this part of myself down a little bit. Just as I said yesterday, being excited to get to teach again. I get to kind of come here and do the things I really like, so you guys are dear in my heart for having me do this, getting me out of New Haven for a little bit. So I'm going to be talking about institutional betrayal today. And, there we go. And what I thought would be most helpful for giving you guys a sense of how it is that I got to where I am, and probably more of interest to you is where I think I might go if I were here. I wanted to kind of give a brief background of where this research came from, how it is that I think about institutional betrayal, how it is I think about the impacts of it, what form it takes, what it looks like in healthcare systems, and then really talk with some specificity, some names even, about some of the things that I think I would be doing here if given the chance to join you guys. So without further ado, I say we jump into the first part. So as many of you have heard a bit in our one-on-one conversations, my work is really grounded in earlier work that was focused on betrayal, but really focused on betrayal that occurred within close interpersonal relationships. And so this is the work of Dr. Jennifer Freyd and betrayal trauma theory. And essentially what this theory is grounded in is the idea that forming relationships that are based on trust and dependency is really a survival instinct and really a survival strategy that we've developed as humans. Like, this is very basic level stuff. We're born pretty helpless. Our caregivers are our primary attachment figures, and we need to depend on them pretty utterly, at least at first. Over time, those relationships evolve, and yet the way we connect with others is through this mechanism of trust. And when that trust is betrayed within those relationships, such as through interpersonal abuse, this is betrayal trauma. So this idea of differentiating abuse that occurs within these contexts where trust and dependency should be the norm, but instead harm is showing up. It's associated with all sorts of outcomes that really set it apart from other sorts of psychological trauma. So very specific correlates in terms of mental health, physical health, and interpersonal functioning. I put some of these specific outcomes up here because I want to start drawing the parallels between interpersonal betrayal and institutional betrayal to kind of flesh out why I started asking the questions I did when I started looking at this in institutions. There was a groundwork and a framework to follow to kind of check this type of betrayal against an earlier set of questions about betrayal. This is also a phenomenon more commonly experienced by women, both in childhood and in adulthood. A lot of this has colored my research interests in women's health care, in issues related to violence against women. I certainly study men as well. This is just kind of the people for whom my work is most relevant. And these questions of who betrays has broadened over the scope of betrayal trauma theory developing. It started out with caregivers. The earliest work was in that area. And over the intervening years, it's really extended outward. Close interpersonal relationships that are romantic in nature, interpersonal relationships that are bound by trust and dependency, but perhaps not romantic attachments, so the military comes to mind here. And over the same set of results, the same pattern of the effects of betrayal, what we kind of refer to as the toxicity of betrayal, has been demonstrated repeatedly. So this idea of trust and dependency, creating the context for betrayal, is one that seems to generalize outward from those initial primary relationships to other interpersonal relationships. So my question really was shaped by the idea that institutions might actually serve a really similar role as individuals do for us. So very often they are trusted, they may be depended upon, and you even see this in the way that we use language to describe institutions. We talk about our university community, you hear lots of family language being used in the military, and the attachment and trust we have in institutions and organizations, and actually I'm thinking of some of Becky's work, this idea of being a part of an organization is something that's actually been framed in terms of attachment and engagement, much the same way as interpersonal relationships. And at the time I was looking to begin my PhD, I knew that I wanted to study traumatic stress, and I've always had an interest in understanding larger social systems. And around this time was Penn State hadn't happened yet, but what was really out and about was military sexual trauma, and thinking about the way that institutions kind of played a part in these traumatic events. And so you would see these allusions in the stories of military sexual trauma, but they also match some references that would come up in literature. And so one area in terms of the legal system that was very frequently referred to as secondary victimization. This is often the case of sexual violence or domestic violence, where individuals who seek legal help, call the police, try to get a restraining order, find that the reactions they get in the legal system are actually a form of further trauma. And this is called secondary victimization. And so there are these ideas floating around, but they hadn't really been operationalized, measured, not really studied in the way that I thought it deserved. And so when I came to the University of Oregon and wanted to ask these questions, this was at a very beginning level of, I think this is happening. I think this would fit within what we know about how people relate to institutions. But if we ask people about it, are they going to identify it? Will people really identify these larger kind of diffuse kind of contextual factors that might surround an already traumatic event? So if we ask individuals, for example, about a sexual assault, and ask them to think more broadly about an institution and how it was involved, will that be something they'll even know what we're talking about? So we started this research at this very ground level. And so thinking about how we ask about institutional betrayal, my background is in psychometrics at this point. I was coming from my master's program at Wake Forest, and writing a scale that was carefully constructed to get at specific measurable events was something that I at least knew how to do. I didn't know what on earth we would find, but I knew how to write the scale. And so these were the first 7 questions, the first way we asked people about institutional betrayal. This was the original set of items on the institutional betrayal questionnaire. We started this work in 2010. I started developing the scale before I actually began classes at Oregon. It's a good way to spend my summer. And what you see here are items we get at institutional actions or inactions, and I'll show you a different way of thinking about this in a second, that are describing things leading up, in this case, in the first several studies I'll talk about, to a sexual assault. Describe things leading up to that sexual assault, so creating an environment where it's more likely to occur or seemed common. And then things that are really about the response afterwards, either in response to reporting, so responding inadequately to the experience it reported, or something about having the experience itself, punishing you in some way for having the experience. So even if you didn't report it to an official source, were there things going around in your institutional environment where you're no longer really a welcome member? You see this happening a lot actually in sororities, to use at some results. For people who think more visually, which is the case of my collaborator, Jennifer Fried, she sees everything in a 2x2. For people who think this way, this is a way of organizing these types of events. So if you think about to continue as you were, things that are acts of commission versus omission is one way to think of it. So failing to act where expected action would occur, or acting in a way that's harmful. And then the other way to think about this is along the second axis, is events that at least initially, because ultimately all institutional betrayal is systemic, but at least initially, do these events maybe seem more isolated? Maybe it's just this person, maybe it's just this RA who I'm telling that isn't responding well. Or are they pretty clearly systemic? And I kind of put some items of the scales into their quadrants where they would fall. And part of organizing it this way was just to kind of give a framework of the very kind of different ways this might at least initially occur, but all kind of organized into the same construct of these are actions that in a context of well-founded trust, safe dependency, none of these should be happening. So it's kind of, they are betrayals on their face, not because individuals are saying, and you notice the 7 questions has no mention of the word betrayal, not because individuals are saying they felt betrayed, but that in a context where safety was a priority, where individuals were well cared for, none of these things should be occurring in that case. Okay, some more. The other thing, just as an aside, not quite an aside, I'll talk about some of these. The other aspect of institutional betrayal that we wanted to measure, and these are items that are after those 7 items that people check off, are these questions. So given this was the first time we were measuring this, we wanted to know, was this an institution that you identified with prior to these events? And in this case, to take like a methodological aside, I was interested in what would happen with this regardless of causality. Because obviously measuring this after the fact can totally be influenced by retrospective, either protective, I never trusted them anyhow, or was really bad because I trusted them so much. I kind of wanted to see what would happen. Over the course of several studies, I have some ideas about what we find with this item, but I can go back to that. I asked if they're still a member of the institution. And in thinking about measuring this on university campuses, there's an entire subset for whom the answer is no, and I have no way of knowing. Because if they've left the university as a whole, it can't be in my study. And yet I thought within smaller subsets of the institution, we could still pick up an interesting pattern. And if they're talking about institutions that occurred before, that they were a part of before the university, if they're not talking about the university itself, you can still pick something up. For that reason, I asked, what institution are you talking about? So they just typed something in this case. So this is the way that I started measuring institutional betrayal. It's pretty intentional, pretty careful. And my sample, I'm going to tell you about 2 different studies that were college students. And the thing that I want to point out that I'm not going to report as part of the results, but I'm actually going to report as part of my sample, is the rate of interpersonal trauma in these samples. So when you measure college students' lifetime experiences of interpersonal trauma, of interpersonal violence, they are not an unusual sample. So they actually are pretty well representative of the US population as a whole. There's nothing necessarily about asking about sexual trauma, asking about lifetime sexual abuse, that makes college students not representative of the questions of the people who I'm trying to understand. They are my sample, they are my population actually. And so that was true in across these 2 studies as well. Quite a high rate of interpersonal trauma. And so in these studies, the questions that I had were whether institutions will be implicated. So this is, will there be people endorsing institutional betrayal at all? Will they know what we're talking about? And if so, thinking back to betrayal trauma theory and the impact of interpersonal betrayal, will the types of exacerbative effects that we're used to seeing with interpersonal betrayal, will they show up here as well? Increased reporting of post-traumatic distress, and a stronger relationship between initial trauma, so sexual assault, and those post-traumatic outcomes. So is there something added, kind of an added toxicity of interpersonal betrayal on top of an experience that we already know is quite traumatic? So trying to tease apart, where does the trauma come in? Is it the sexual assault? Is it the institutional betrayal? Do they work together to create a worse outcome? So what we found, institutional betrayal was indeed common. So about 40% of the students who had experienced a sexual assault reported institutional betrayal, at least one of those items on the IBQ. Now, I made sure to emphasize the fact that we were asking about lifetime trauma. So we didn't, because this was our first study, we wanted to cast a wide net. So when we ask about sexual assault or unwanted sexual experiences of any type, we ask their entire life, not since they were at the university. But what we found is overwhelmingly of the people who reported institutional betrayal, the most common institution was the university. And this stands to reason at some level. They were, in later studies, we kind of tease this apart a little bit more. They were college students at the University of Oregon. Now, they could have transferred. They could have transferred from another university, it might have been a different school. And yet, a perhaps more parsimonious explanation was that we might have been studying institutional betrayal at Oregon without necessarily intending to at first. Later, we very much so intended to study that, and I did. But in this first study, we see the institutions overwhelmingly being the university or school system. Greek system, I realize not everyone has gone to a school that refers to it this way. These are sororities and fraternities. Okay. In terms of the question about the effects in how we would expect institutional betrayal to be associated with post-traumatic distress in keeping with betrayal trauma theory, we also found that. So these are correlations with the Institutional Betrayal Questionnaire, the Trauma Symptom Checklist Scale. And we find higher rates of dissociation, anxiety. That acronym, SATI, is Sexual Abuse Trauma Inventory. It's like a subscale of the Trauma Symptom Checklist. It gets at things that actually map really well onto the primary care PTSD checklist that some of you saw yesterday. Kind of hyperarousal, intrusive dreams and thoughts, kind of just like a subset of post-traumatic responses that are kind of blended together in this acronym. And then interpersonal dysfunction in the case of sexual functioning and intimacy specifically. The question of whether what we were seeing here was about the sexual assault itself or institutional betrayal comes up. So all of the individuals who experience institutional betrayal by default experience a sexual trauma as well. So trying to understand when we see higher rates of these trauma symptoms, is this people who've either had more extensive sexual assault experiences, so several sexual assaults? Did they have a more severe, more coercive or violent form of sexual assault? This is a question that came up at this point. And in actuality, looking at the data, being able to tease apart by either the number of sexual assaults or the measure of sexual assault that we use as a sexual experiences scale, which actually organizes experiences by physical coercion as well as the degree of, I guess penetration is the best word, so it kind of goes from kind of physical sexual themed assault to penetrative sexual assault. If you look at people's experiences across these categories, the rates of institutional betrayal didn't actually differ across the types of experiences. So reporting institutional betrayal actually didn't seem like a marker of severity, for example. Like people who've had more sexual assault or a more violent experience weren't just therefore more likely to say, well, also an institution was involved. It's not a marker of severity. In terms of the question of the exacerbative effect, that I did find. And so if you look at this graph, what this is showing is an interaction. And the thicker line are people who've experienced institutional betrayal. And the thinner line are people who had a sexual assault but had no institutional betrayal. They didn't endorse anything on IBQ. And what you see here and across these four subsections where you saw the correlations before, a relationship in which the rate of symptoms of each of these areas of dissociation in this case, in this graph, was higher for people who've experienced institutional betrayal in addition to sexual assault. And this was a nice kind of common linear relationship across the number of items on the sexual experiences scale that was endorsed. We see this exacerbative effect where it's not just the sexual assault driving the trauma symptom checklist responses, it's the institutional betrayal on top of it. So this was the first study that I did in this area. And these results were right on track with what I thought I might find if institutional betrayal did indeed map on to what was happening with kind of more general betrayal that we see in interpersonal relationships. And I can talk a little bit later if you guys are interested about my theory about why this might be. My sense is institutional betrayal acts as an almost inescapable trauma stimuli. It's hard to escape an entire institutional environment. And that comes to bear in some of my more recent research in healthcare systems and chronic stress. But the next study I want to briefly touch on, because it goes into my interest in healthcare systems, is a study that I also did at the University of Oregon, where I wanted to understand more clearly the effect on physical health that institutional betrayal might show, given the research on betrayal trauma in general and its effect on physical health. And I also wanted to dig a little bit deeper into this dissociation finding and think about dissociation and memory in response to institutional betrayal. The reason for this is one of the mechanisms that most often co-occurs with a betrayal trauma, especially when remaining in the relationship is a necessary option. It's quite hard to maintain an awareness of ongoing abuse and betrayal in a relationship that you also need for survival, in part because it's just kind of psychologically difficult to know that type of thing, that someone that you care about is also capable of harming you. But especially in the field of child development and attachment, the types of behaviors that children kind of exude towards their caregivers elicit caregiving responses. So they're very open, they're warm, they make a lot of eye contact, they're very vulnerable. And those responses actually don't go along with betrayal and abuse very well. Or rather, if you think about a situation that you might find yourself in a less charged situation, if you find out, for example, a friend or a loved one has told a secret that they swore that they would keep for you, what are your responses? What are your options in that situation? What could you do with that? Unexpected audience participation. What would you do?
Not tell them anything else.
Yeah, so you withdraw. Would anyone maybe confront them? Ask.
Oh, yeah.
Yeah. Weren't sure that was appropriate response.
Confrontational person at the table.
Yeah. So these are really natural. These are our two options for responding to harm in an interpersonal relationship. Both are designed to protect us from further harm. So you either don't tell them anymore, okay, you can't betray me again, or you confront them about it. Cut that out. Don't betray me anymore. In a situation where you're not empowered to do that, those actually aren't viable options. If you can't risk losing the care that's available in the relationship, or you can't risk that caregiver withdrawing from confrontation, then your option is trying to figure out how to have this knowledge and maintain this relationship. Those two things actually end up not being very compatible. So what we see is higher rates of dissociation and more difficulty remembering high betrayal trauma. And so in this case, when I thought about how this might play out in institutions, I wanted to more carefully ask, does institutional betrayal affect dissociation in this similar way? So I use a different scale, a more kind of fine-grained scale of cognitive and behavioral dissociation, the WESIX. And I also asked about continued membership and memory.
Carly?
Yes.
I know what dissociation is in a lay sense, but could you please refine that?
Absolutely. Yeah. So to meet you a bit on a personal level, dissociation is probably one of my favorite psychological coping mechanisms, if you're allowed to have those. Dissociation is essentially distancing yourself from current reality. So it's about the opposite of mindfulness for people who were in the Mind-Body lecture yesterday. Depending on your theory, your kind of school of thought, it's a protective mechanism that separates an individual, at least consciously, when you can't separate bodily from an overwhelming stimulus. And so you see things on scales that measure dissociation, like feeling detached from yourself, feeling unable to connect with reality and not in a psychotic way, having difficulty remembering things that you've done even very recently. So it's kind of a lack of connection to your current behavior, your current functioning. Does that make sense? Okay.
There's one more question.
Yeah,
So
please.
Are these scales sort of momentary scales or global?
I'm guessing you're asking, did they respond in terms of how they generally are or what's happening for them right
Yes.
now? How they generally are. Yeah, so the dissociation is more kind of trait level in the way that this scale works. I usually have those kind of questions. Mm-hmm. And the other thing that I won't spend too much time on, I added some items to the IBQ that were arising actually specifically as I became more involved in campus sexual assault research and started hearing more about some of the institutional actions that would arise in responding to campus sexual assault specifically. So, what did we find in terms of health? So, institutional betrayal in this case was associated with higher rates of endorsing health problems. These are some of the subscales or some of the items on the patient health questionnaire. Yet, again, I want to think about the fact that anyone who's experienced institutional betrayal has also by default experienced some sort of sexual assault in this study. So teasing apart, is it the sexual assault driving these results, or is it the institutional betrayal? And in this study, a unique thing was that I actually used a measure of interpersonal violence that took into account interpersonal betrayal. So I could take into account, was it the interpersonal betrayal? Was it the institutional betrayal? What if you have both? So what if you have both turns out to be a real bad situation to be in. So the highest rates of health problems was associated with individuals, or were occurring in individuals who had both high institutional betrayal and high interpersonal betrayal. So the sexual assaults that they were talking about were perpetrated by someone close to them, and they endorsed at least one item on IBQ. So kind of a double whammy of betrayal here. Yep.
Two questions. I'm wondering if you validated the institutional betrayal scale, and I'm wondering if there is something else that explains the differences that you're finding,
Yeah. What do you think?
like a personality characteristic. So
Yeah.
so there's something sort of more fundamental than the institutional betrayal that explains why some people score high on the institutional betrayal scale than might not.
What kind of like personality style do you think might be associated with that?
I don't know.
Okay.
But I don't know.
I haven't answered your question, and I'm wondering if you'd be willing to wait till the end because I have a slide for it. Okay.
Sure.
Thank you.
Yeah.
And the first question was about validation.
Right, related to the
Yes.
Yeah.
Okay. So the full answer to that will perhaps wait till the end a little bit, but in terms of asking the questions I did about what type of outcomes you would expect to see associated with institutional betrayal, given what we'd expect from interpersonal betrayal, it was functioning as a validation. These are the outcomes you'd expect, the kind of concurrent validity. If this was functioning like betrayal, if it was measuring what I expected, these are the outcomes you'd expect. Does that make sense? Cool. Okay. Onto the question of dissociation in this kind of combined interpersonal and institutional betrayal. Again, highest in the high interpersonal betrayal and the institutional betrayal condition. And just as an aside, dissociation is not an unusual experience necessarily. It's not always pathological for folks who had neither interpersonal nor institutional betrayal. Still have dissociation going on. Everyone does it a little bit. In terms of the memory and dissociation as a protective function, think about the question on the IBQ that asks, are you still a member of this institution? So if the people who say yes and have experienced institutional betrayal, or for the people who say no, who do you think would have a higher rate of dissociation in keeping with betrayal trauma theory, in keeping with the predictions?
people who say yes.
People say yes. It's totally right. So you see a higher rate of dissociation for folks who say that they're still involved with the institution compared to those who say they're no longer a member. Okay. So, shall we go on to healthcare systems? So this is the groundwork that I was going into, and there's many more studies, and it's hard to not talk about all of them. But this sense that institutional betrayal was functioning much like interpersonal betrayal, had many of the same mechanisms happening in response to it, actually had me starting to think about healthcare systems in a context where worse health functioning was an outcome, a tendency to actually leave the institution. So this is a result that I didn't get to show you. I have across the several studies that I did while I was at Oregon using this scale, I got to ask, are you still a member across about almost 10 different studies? And over again, about 50% say no. The rate of leaving following institutional betrayal is roughly 50%. Those two things in combination, worse health functioning and a tendency to leave in response, really had me thinking about healthcare systems, because this is a system whose values are all about improving health and whose mission is directly impacted when the patients stop coming back. And so if institutional betrayal is happening in healthcare, I thought we would have a whopper of a discussion. And there's other reasons to kind of look for and ask about betrayal in healthcare systems. a lot of language in medical research around patient-doctor relationship is colored by trust. And this idea that trust is a critical component of the healthcare relationship is something I know everyone here is familiar with. And yet, as an aside, reading quite a lot of this research in preparation to do a dissertation on this topic, a thing that stood out to me overwhelmingly is the source of trust in the medical discussion was the patient. Why don't these patients trust us? What can we do? What is it about some patients that makes them more trustworthy than others? Is there something we can do to kind of keep the ones who don't really trust us, keep them in anyhow? It was this discussion that was like, guys, you know you're in there too, right? Like you see that you're also in the room, but the recognition of physicians paled only in comparison really to the recognition of any type of institutional factors that might be affecting patients' trust. So I saw a real opening here. The language was there, but it wasn't being asked broadly. There was some precedent to asking about engagement in healthcare as a function of trust, and this was a really work that was mostly happening in the VA. And a lot of this laid the groundwork in terms of, okay, these are questions to be asked, and yet I had kind of a problem at the outset, because so far, all of the research I had done had really focused on institutional betrayal as an exacerbated factor in sexual trauma. Plenty of folks, as my teaching discussion talked about yesterday, plenty of folks with trauma are in the healthcare system. Yet, when I think about the way that I wanted institutional betrayal to evolve as a construct, I didn't necessarily only want it to be something that was associated with sexual violence. I wanted to understand, is this something that occurs in response to any kind of negative event that occurs within an institution? And so in this case, a negative event that might occur within a medical institution is just kind of an unexpected medical event. Treatment not going as planned. And the Institute of Medicine actually has a wonderful set of studies on the most common types of negative medical events, including these minor mix-up and mistakes all the way through really egregious medical errors resulting in patient death. There's an enormous burden of disease cost associated with that, and they're really common. And so I thought, if these things are happening really widely, is this a thing that I could ask about institutional betrayal surrounding and see if it kind of holds up as the same type of effect that we see in the response to sexual assault? There was not a very succinct measure of medical errors or negative events, and so I had to make an inventory of my own. But following the Institute of Medicine's checklist of the most common types of medical events, I had some groundwork. So medical errors were one set of events, and so things like being given an incorrect diagnosis. Adverse consequences of treatment was another category of events, and so examples such as having an allergic reaction to medication. And then unexpected or lasting pain seemed to be another set of events, so things like had a procedure that was more painful than they expected, or having to return for emergency care that wasn't meant to be part of their treatment plan. And I don't know if folks are noticing the acronym, NEWAD assessment. This was a small amount of joy as I was writing my dissertation. And so this was essentially a checklist of events. In thinking about measuring institutional betrayal related to these events, it required being really focused with how the IBQ was presented. I really wanted to be clear that when I was asking people about their experiences in healthcare and they were telling me about institutional responses, that they were very clearly focused on a healthcare institution. I didn't want to accidentally pull in someone who told their coworkers about their healthcare and were kind of like invalidated. I wanted to be really focused. So the instructions look different. I want you to think about healthcare institutions. And I've talked with some of you about this. It could be parts of the system. It could be the entire healthcare system when you kind of think about US healthcare that's just not set up to help me. I wanted to kind of capture everything I could. And the items themselves looked a little bit different as well. So still the same stems, failing to take proactive steps to prevent, but putting in healthcare wherever I could fit it. Really want you guys to think about healthcare. And the same function, people would check these off if they'd experienced them. Only people who experienced some sort of adverse medical event, so had any item endorsed in the medical book, saw this IBQ. And in thinking about this question, so no longer is it, does institutional betrayal exacerbate sexual trauma? It's a question of, does it exacerbate items that occur on the mea culpa? Does it exacerbate these types of negative healthcare experiences? And the same outcome areas were of interest: physical health problems, mental health problems, post-traumatic distress. There's a huge literature on the trauma of medical experiences. I wanted to see if this would map on. And some psychosocial functioning. And finally, getting back to that initial literature on trust, is this a missing piece? Is this the piece that isn't really being discussed in healthcare? It's not just something about the patients that they're bringing, but it's something about the institutional betrayal that they're experiencing that's negatively impacting trust. So I want to talk briefly about the sample, in part because this ended up being a really wonderful part of this study and something that I intend to continue using. So Mechanical Turk is a service on Amazon, and it's an online marketplace of individuals who participate in online tasks for pay. It is incredibly diverse, and I could talk for ages about the incredible people on this site. They actually ended up, much like the campus sexual assault samples that I would have with those college students, they ended up actually being my target audience. So a lot of their message boards, I kind of got into their community a little bit and would read about them. A lot of them are working from home, doing this online work for pay because of chronic health problems. So what started as a convenience sample of being able to collect a huge amount of data relatively quickly ended up being the people who I actually think could benefit from this research most directly. So institutional betrayal in healthcare, what did we find? It was hugely common. So if you remember the sexual assault research that I presented earlier, about 40% endorsed at least one item on the IBQ, it was way more common in healthcare. It was about 66%. Some people, as a clarification, endorsed a negative medical experience, no institutional betrayal. They weren't hand in hand. Most common mea culpa items was being prescribed, so these are percentages and the item. Unnecessary medication and an incorrect diagnosis were kind of the top two most common. Roughly, a little bit over a quarter of the sample endorsed having those experiences. The most common form of institutional betrayal was failing to take corrective steps, and then a kind of close tie for responding inadequately or denying your experience in some way. So one of the things I talked about earlier with Erica Saunders is actually an intervention for healthcare providers or training them to do validation techniques that addresses these two items directly. I'll go briefly through some of the other results because they parallel really closely the results I presented in the campus sexual assault research. We found the same pattern. So physical health symptoms, if you look at the colors, so this is blue, orange, and green from afar. Green are individuals who experience institutional betrayal. A nice comparison is the orange bar. So these are folks who had experienced those negative medical errors that prior research in Institute of Medicine had indicated were associated with worse physical health and mental health outcomes. So these are kind of the control group. Institutional betrayal was associated with higher physical symptoms. So the pill is an inventory that's like a checklist of physical symptoms. It was also associated with lower health functioning. So the short form 36 is an inventory of how much you're impacted by any physical health problems, how much it limits your daily activities. I've got a couple of these models, and I will walk you through these. These fill me with joy. I'm guessing that's not a universal experience. So I made a soothing color. So what these are path models. And what a path model allows you to do is still test models of causality even in single time measurement data. So data that would normally be treated as purely correlational, you can test the goodness of fit of a causal path. Does it make sense, for example, given the data, to trace a path? Does it fit the data best if we trace a path that goes from negative medical experiences, so items in the mea culpa, being associated with institutional betrayal, which leads to non-compliance behaviors, withdrawal, so the pattern of withdrawing, disengaging from the institution. I also measured that as part of this study, asking folks, do they not go back to the doctor when they were told to? Do they not follow up on care? And is that actually how we get to this worse physical health? So testing a potential mechanism of institutional betrayal in healthcare. The data fit that model quite well, better than any other kind of iteration of this. Are people with worse physical health just more likely to have institutional betrayal? Does it go that way? This was the best fit model. The same pattern showed up in mental health. We see most association in the group with institutional betrayal. We see most depression in the group with institutional betrayal, and the highest rates of post-traumatic distress, post-traumatic PTSD checklist here. The final thing that I want to talk about in terms of mental health and memory, I asked in this study directly about forgetting. Was there a time, and the measure that's used is actually a betrayal trauma inventory that measures forgetting directly. Was there ever a time where you could not remember these events? You couldn't remember the negative medical experiences. And for people who checked any of these items, they experienced some sort of forgetting. It might have been in the past, the memories come back, it might be current, they used to kind of know about it more. And in terms of comparing people who had experienced institutional betrayal in healthcare versus not, this is a way to test whether people maintain awareness following this type of betrayal. So for people who had not experienced institutional betrayal, their rates of forgetting those negative medical events were really low, about 8%. For people who had experienced institutional betrayal, it was huge. 85% of folks who had experienced institutional betrayal reported at some point not being able to remember those negative experiences they had in healthcare. So in terms of the implication that has for interacting with our patients, when we ask them about their medical history, when they ask about past experiences and treatment they've had, those things where sometimes we don't get that good of data, and then it's kind of back on the patient, you're being a bad reporter, you're not kind of giving a good history, there might actually be another reason for those poor histories.
So they both had the same baseline incidence of negative experiences with healthcare.
So these are people who endorsed anything on the mea culpa, so they had negative
But
experiences.
were there more on the did they endorse more items in the institutional betrayal column than the non-institutional betrayal column?
So these are two groups. So these people have checked nothing on the institutional betrayal column. So this is the part of the sample who had negative healthcare experiences but no institutional betrayal.
I'm sorry, medical.
Ah, got it. Were the rates of medical errors different in these two groups?
Correct. That's
No,
what
they
I'm
were
trying
not.
to ask.
Thank you. Yes, good question. So the final thing in this study that I want to talk about in terms of the trust in physicians, what this model is showing is that negative healthcare experiences do actually lead to lower trust in physicians, but that institutional betrayal actually explains this relationship. And it explains it more strongly, it explains it more fully for people who reported that initially this was an institution that they had trusted more. And at this point, I started doing a whole bunch of research and looking to the literature about retrospectively changing how much you say you trust someone or an institution, because this result becomes a lot less compelling if people tend to adjust their reports of how much they used to trust someone who's betrayed them. And the field of actually couples counseling and divorce counseling gave me a pretty good sense that actually the changes over time that couples report following infidelity don't tend to be mismatched. People are able to accurately report their degree of trust in a partner that they had prior to finding out about the infidelity as after. This isn't a perfect model, of course, but it's starting to try to get a sense of when we ask people how much this was an institution that they trusted, their reports might actually be accurate. This also lends itself, of course, to doing longitudinal data collection. I really would like to test that as people go through treatment. The final thing in terms of the trust in physician, trusting your individual physician actually does buffer the relationship between institutional betrayal and how much you trust healthcare organizations as a whole. So intervening at the doctor-patient level, intervening in how physicians talk to their patients about institutional betrayal, I actually think can be quite effective. They play a very protective role. I actually think I'm going to skip the next slide and discuss it if it comes up. So, the thing that I want to conclude about healthcare research here, institutional betrayal in these settings is common. It exacerbates the fact of medical errors across the field, across the areas we'd expect given how betrayal works. So physical functioning and health, mental functioning and memory, and trust in physicians and institutions. Trauma matters immensely in this, but in a way that you might not expect. And I'm happy to show you the PATH model again that I think might, based on some of your facial expressions when the others are up, might be more simply explained in words. Folks who have more trauma in their history have worse health functioning. They come to doctors more. They show up in our systems more. As a result of that, they're at a higher risk of being exposed to institutional betrayal as a result of medical errors. It's just an increased exposure effect. Trauma doesn't make them more likely to report institutional betrayal. That wasn't the case in this data. It doesn't put them at a higher risk for medical errors once you control for their number of visits. It's purely a matter of a higher exposure rate. So I want to end with where I think this research can go here. And that has two main areas. So first is the one that I've already started with collecting qualitative data from Yale residents, is understanding the role of doctors and how they might come to absorb some of this institutional betrayal themselves, how they might experience betrayal in their training as they're asked to maybe take on institutional norms they don't agree with, that don't fit who they are as people, but also how this affects their own kind of perception of what the patients are doing. That pattern in the medical research and the literature of attributing low trust to patients, that doesn't spring forth fully formed. The lack of an ability to see the institutional context, I don't actually think that's natural. I think that might be learned. Those are the questions I'm asking in the research that I'm doing this year. I'm also going to be asking questions about changing residencies, dropping specializations, because I know from past research that institutional betrayal tends to make people leave. And I want to know if that's happening in our medical residence training. I had some conversations with many of you about how this might factor into the education and teaching I do, and particularly how it might function as a form of ethics and kind of understanding doctors' roles in institutions. The other area, though, and this is some of the research I talked about with Dr. McCall-Hosenfeld and Dr. Weissman, looking at patients who are at an increased risk of exposure to institutional betrayal given trauma histories. And finally, there are no medical students here that I could entice into research, but I have a ton of available data sets that have questions about institutional betrayal and health. Tell them about them, hopefully they would want some help. And I'm completely open as I talk about those other those other projects of having them participate. So with that, we'll end. Ask for questions, discussion. Thank you guys. Becky, I have a picture just for you about your question. So we can start there if you want. Okay. So a organization of personality that you might expect is someone who has a bit of a more negative outlook on the world. People are out to screw me, the institutions can't be trusted, that kind of expectation. So I actually measured that as part of this study because I wanted to make sure that wasn't what was driving this. And that have people who scored higher on those qualities, this negative world assumptions, it's a well-used measure, it had no predictive power on the relationship between negative medical experiences and the likelihood that you endorse institutional betrayal. It didn't explain the relationship between decreased trust in physician following either institutional betrayal or negative medical experiences. So it's not that it might not be something else, it just doesn't seem to be this.
I'm not sure if this is a question. I guess I'm struggling a little bit with the analogy between a sexual assault by someone you trust and a medical mistake made by someone you trust. I mean, one is potentially more an act of omission. You didn't check on this, you missed the lab, you didn't order the right thing, you didn't do the diagnosis. Whereas the other, I mean, is an assault. I mean,
there's no mistake in that.
And the nature of the relationship between the doctor and the patient is that it's unambiguous. supposedly it's unambiguous that the goal of that relationship is that the doctor's trying to help the patient and get them in a state
Yeah.
and not achieve that goal, but that's unambiguously what it is. A sexual assault, I mean, you can't make an analogous sort
No, you
of
can't.
claim that, oh, I'm
Yeah.
trying to help you by sexually assaulting you.
Yeah.
I mean, it would be hard pressed to do that. And so I'm just trying to wrap my head around, how you got from
Yeah.
that to this, and if it entirely applies as a model.
So let me actually jump in there, because you don't have to make that analogy, because I'm not.
Yeah.
So the idea of measuring institutional betrayal is more about understanding how an institution responds to an individual who's experienced something that shouldn't be occurring in that context. That's all it is. It's not trying to draw a parallel between sexual assault and negative medical experiences at all. Does that make sense? Or at least kind of alleviate your concern there a little bit?
Yeah, I mean,
Okay.
if it doesn't help, it's
Yeah.
not dependent on that analogy working.
No,
It's
definitely is not.
Yeah.
So the one thing that was in my head as you were talking about this is, I'm one of these institutional reporting people, so I have to do the Clery Act training.
Mhm.
And that's a great example of how something bad happened to that student, but it was an huge institutional trust issue.
Yeah.
And so in this case, it's the trauma of the sexual assault that is the parallel, not
Yeah.
what the intent was. And to some extent, that's the separation, I guess, that your collaborator makes between things that are omission versus commission, that there are a whole bunch of things that happen in the omission category of, so if we as an institution are not doing the types of things that could have prevented that medical
Yeah.
error, are we, that's an omission, and so that it falls on that scale, I think. And if we don't, if as that Lehigh University doesn't create a safe environment by making people aware that stuff happens, then they're responsible,
Yeah.
and they've betrayed that trust. That was, I don't know if that's what was resonating with me as I was thinking about that, because it was a lot of the same words and a lot of the.
Yeah, Dan.
So if we could wave our magic wand, it's 10 years from now,
Oh, man.
your research has thrived,
Mhm.
things have gone really well. What could potentially be different in healthcare as a result of your work?
Yeah. So a change that I think would be, I'm not going to use the word easy, but a change that I think would be most impactful is that physicians ask about these experiences, that this is commonly discussed in a healthcare setting where, are we doing an okay job preventing? You had something kind of go wrong. Is there a way we could have prevented that? Is there a way that, when you brought that up, really making sure patients' concerns are taken seriously? I almost think about internalizing the items on the IBQ as kind of a self-check and a systems check. So it's not something that on the back end people are reading for the first time and going, yeah, this is what happened to me. Like, how come no one has put a word to this before? While I really love that my research connects with people in that way, I'd much prefer that people have this construct in their head as a way to check their own behavior. Does that make sense?
Mm-hmm.
So, part of the reason I would think why institutional betrayal is in a healthcare setting is important and interesting is because of its negative impact on like morbidity, mortality, or
Yeah.
health outcomes. Yeah.
Mhm.
So when we were looking at data that was about that half of the equation as opposed to like
Mhm.
whether or not they experienced something and whether that prompted institutional betrayal, it's sort of the first half, but then the second half is if the institutional betrayal is related to negative health outcomes.
Right.
It seemed like, so in the first study of correlations, I know just enough statistics to be like really dangerous. So please tell me if I'm way off base
I can help, that's
yeah,
fine.
okay.
Keep going.
So in the first study that you presented, the correlations were like 0.1,
Yeah.
so super low.
Mm-hmm.
And then as we're looking at bar charts, the whiskers, the whiskers are super close and in many instances overlapping amongst the different bars, and the anchoring on the left is really tight, right? Like it's 1, 1.0, 1, 1.2, 1.4.
Mhm.
So I guess my question is, there's a relationship between
Yeah.
institutional betrayal and health outcomes, but
Mhm.
do you think that it's statistically significant, but maybe not clinically significant?
Yes,
and any
I
intervention that we
understand.
might not, that we might, devote a bunch of time, effort, and energy in doing wouldn't actually move the needle on
Yeah,
what
that's
we're seeing in the real world.
a totally fair question. So it's a question about effect size and clinical significance.
Yeah.
In the context of measuring kind of behavioral effects on health outcomes, or in the context of measuring, for example, like the classic example you get in population health research is the effect of aspirin on heart attack and the reduction of risk in taking an aspirin. And the effect size is actually pretty small, but the clinical significance is huge. And so the idea of preventing a heart attack by taking this aspirin, I'm not going to draw a direct parallel between that and institutional betrayal, but I think the clinical impact is actually quite significant because changing the rates of institutional betrayal is actually really well within reach. It's not an entire population shift, it's not an entire behavioral change. But in terms of the effects of social science variables, personality, things like that, on health outcomes, this is actually really kind of on the same level as those. It's right in the realm of the typical effect size that you see for these types of kind of person variables or personal experience variables and health outcomes. So it's not, you're right that it's not like a 50% reduction in this, but I don't know that anything really that we know about from the social science end has that type of impact on health, that type of big change, but I actually think the clinical significance still stands.
We're gonna,
There's a
one more question and then we need to go for Corey's lunch.
there's a fair amount of talk these days around from medical students around professional identity formation and this idea of what people call the hidden curriculum, which is a buzzword for organizational culture.
Yeah.
I guess my question would be, how would you speculate for students coming to a school, how, if at all, institutional betrayal is felt in the role of the student might factor into this equation of organizational culture and students' professional identity formation?
Yeah, so that's actually a wonderful question and really the focus of my research this year at Yale. Because I actually think medical students and more kind of residences are in the clinical thick of things and acting as physicians. I think they're pretty vulnerable to this because they still have that sense of what they think the kind of human thing to do, and they've started doing some preliminary interviews. And the theme so far is that human part is they're repeatedly asked to kind of tamp that down a little bit, even though outwardly they're encouraged to have this relationship with their patients, cultivate trust. And so I think that sense of betrayal that they would feel of like, wait a minute, I got to this field to help people, to change people's health for the better, to do the best I can. Asking to kind of bring that down, I think, is a huge source of disappointment and disillusionment.
Thanks, guys.
Thanks.
Yeah.
Thank you.
Thanks so much.